Hey everyone, my name is Taylor and welcome back to my channel where we analyze medical case studies. Today I'll be discussing a case in which a series of mistakes unfortunately led to the death of a 61-year-old woman named Mrs. B. Let's take a look and see what
Mrs. B
happens.
arrived at the ER in a rural Ontario hospital around 8:15 p.m. and was assessed by the triage nurse, Joan. Mrs. B reported a sudden onset of severe chest pain, which radiated down her arm, back, and neck. She rated the pain 10 out of 10. Mrs. B also reported a history of hypertension and smoking. Joan took Mrs. B's blood pressure, which was 228/104, and she assigned Mrs. B a C-test level of 3. The attending physician ordered a diagnostic panel including chest x-ray, placement on monitor, nitroglycerin, and GI medications, but it took an hour for Mrs. B to be placed on the monitor or to be given medications. The test results from the diagnostic panel came back normal. The attending physician contacted Mrs. B's primary physician, who had her admitted for observation, and ordered a blood thinner. Later that night, her condition still hadn't improved, so they did a second ECG, and the attending physician diagnosed an acute inferior wall MI. The hospital did not have the capability for heart surgery, so Mrs. B was transferred to another hospital for cardiac catheterization. The catheterization revealed that Mrs. B had an ascending aortic dissection requiring emergency surgery. During the surgery, a large hemorrhage and hematoma were discovered, and the surgeon felt that Mrs. B would not survive and decided not to proceed. Mrs. B died about a week later.
So in all seriousness, this is a very unfortunate case that happens far too often. After a quick literature search, I found that aortic dissections are misdiagnosed up to 39% of the time, which is quite high considering the fact that aortic dissections can be fatal if not treated with emergency surgery. So let's dissect where things went wrong and see how we can learn from it. The first thing I'd like to discuss is the triage level that was assigned to Mrs. B. The case study claims that she presented to the ER with severe radiating chest pain and an extremely high blood pressure. So right away, based on these modifiers, Mrs. B should have been assigned a level 2 instead of a level 3. It's hard to say, though, if this would have changed the outcome, because when she finally did see a doctor, they still failed to do any appropriate assessments or diagnostic tests. So in my opinion, even if she would have been treated sooner, they still would have missed the fact that she was having an aortic dissection. So let's take a look at the initial triage assessment and see what could have been done better. In my opinion, the initial triage assessment was completely inadequate for several reasons. First, the triage nurse should have taken and documented a full set of vitals. Secondly, she should have done a more in-depth pain assessment with the PQRSTU method, because many people who are having an aortic dissection will describe the pain as a ripping or tearing pain, and if Mrs. B had described her pain like this, it may have alerted the healthcare team to the fact that she was having an aortic dissection. Thirdly, the triage nurse or the physician should have performed a complete cardiovascular exam. While the signs and symptoms of an aortic dissection can be quite vague and often mimic a heart attack, there are a few key signs that can indicate an aortic dissection, including an aortic murmur, a pulse deficit, and a blood pressure difference of more than 20 millimeters of mercury between the two arms. So if anyone had listened to Mrs. B's heart, felt her pulses, or checked her blood pressure in both arms, they may have noticed these signs and been able to diagnose her earlier. It also would have been helpful to get a more complete medical history from Mrs. B, including what medications she was taking. Specifically, it would have been helpful to know if she was on any cardiac medications or any medications that could cause bleeding. Another thing that's quite concerning is the fact that it took an hour for Mrs. B to be placed on a cardiac monitor, which is just careless in my opinion. The Canadian guidelines for the management of acute coronary syndrome state that anyone presenting to the ER with chest pain should have an ECG taken and evaluated within 10 minutes of arrival. So this should have been a priority regardless of how busy the ER was. That being said, though, I don't think it would have changed the outcome, given the fact that her initial ECG was completely normal anyway. I think the two biggest factors that led to Mrs. B's death, besides the inadequate initial triage assessment, was the fact that the healthcare team failed to do any follow-up assessments to try and figure out what was wrong when her diagnostic panel came back normal. From the case study, it seems like they just waited and observed her until she had a second ECG much later in the evening. But they should have immediately done more tests and investigated further what was causing her pain, especially because she was rating it 10 out of 10. Ideally, she would have had a CT scan or an echocardiogram, which are both highly accurate ways to diagnose an aortic dissection and are actually the only definitive ways to diagnose them. So Wang and colleagues actually suggest that echocardiography be readily available in the emergency department and should be completed concurrently with an ECG within 10 minutes of arrival to prevent the misdiagnosis of aortic dissections. The other thing that I think contributed to her death is the fact that the family doctor prescribed blood thinners over the phone, even though at the time there was absolutely no indication that she was having a heart attack. I think this was irresponsible of him because he prescribed this without even seeing the patient and before he had a full clinical picture of what was going on. The blood thinners probably made things much worse and contributed to her bleeding during surgery. From my literature search, I found that this happens far too often. Blood thinners are inappropriately prescribed to people having aortic dissections about 25% of the time, and this can contribute to a higher long-term mortality. So all of this being said, I think that the triage nurse, the ER doctor, and the family doctor all played a role in Mrs. B's death, and I don't think it's fair to say that one is more responsible than another. I think they all equally contributed to her death. But I'm interested in hearing what you think. Who do you think is primarily responsible for Mrs. B's death? Was it the triage nurse, the ER doctor, the family doctor, or the whole healthcare team? The last thing I'd like to point out is that this case could have gone very differently had Mrs. B been at a large hospital in an urban area like Toronto, for example. Mrs. B was treated at a rural hospital and in the evening when diagnostic imaging services were probably unavailable. Also, had Mrs. B been at a larger hospital, they could have started the surgery immediately instead of transferring her to another hospital. This delay in surgery probably contributed to her death. But I want to know what you think. Do you think Mrs. B would have survived if she had been treated at a larger hospital in a city? And what do you think can be done to prevent discrepancies in care between rural and urban hospitals? That's all for this week. Thanks for watching, and I'm looking forward to hearing your opinions.